Welcome back to The Exam Room, a podcast where we dive deep into the world of value-based care, patient-centered healthcare, and improving health outcomes with your host, Dr. Rhiannon Winsor. Dr. Winsor is a certified surgical technologist, healthcare educator, and the manager of training at VB Care Network. With almost 30 years of experience in healthcare and instructional design, she's spent her career helping clinicians and care teams optimize patient outcomes.
Hi everyone, welcome back to the exam room. Today we're talking about one of the biggest cracks in our healthcare system and one that community health centers feel deeply. Too many nurses are leaving the profession within their first year, especially in rural and underserved settings. FQHCs and community health centers are often doing mission-driven, complex work with limited resources, and yet they are expected to recruit, onboard, and retain a workforce under intense pressure. How we support nurses, reduce silos, prevent burnout, and build systems that help people stay, grow, and thrive where they live is critical in that first year. For today's conversation, I'm joined by Heidi Sanborn, Clinical Associate Professor at ASU's Edson College of Nursing and Health Innovation.
I gotta stop you. Sorry, clinical professor.
Sorry, I forgot to take
associate.
that out.
Yeah.
That's my fault.
That's okay.
Okay, 3 times the charms.
Yep.
For today's conversation, I am joined by Heidi Sanborn, Clinical Professor at ASU's Edson College of Nursing and Health Innovation, whose work sits at the intersection of nursing, leadership, innovation, and systems design.
Thank you so much for having me. I'm excited to be here.
I'm so excited for this conversation. So before we dive into solutions, I'd love for you to share a bit about your own journey.
Sure. I think my story actually translates into the kind of nurse I am today. So I always love sharing my history. I came to nursing not ever thinking I wanted to be a nurse. I had a career in the tech industry as a business manager for a small software company. Thought I wanted to go to law school. And yet within 10 years of graduating with my bachelor's degree in business, I became a nurse. I fell into it completely by accident. And in hindsight, I don't know how I didn't come to that decision earlier, because it's absolutely where I was meant to be. So I straddled both worlds for a while as I was going back to nursing school and going through the stages of my career change. Then I entered into nursing, and from there, I've sort of followed this trajectory of let's see where the wind blows and what doors open and walk through them if they seem interesting to me.
Mm-hmm.
So I have experience as a bedside nurse across multiple different service lines. I've worked in leadership in the clinical setting. I then moved over into education, and that's where I've spent the last decade of my career is bringing up the next generation of nurses to enter the workforce.
Wow, that is amazing. You bring so much to the table, and I'm so excited to unpack this discussion with you. But I had a thought as you were telling me about how you started out in this area of technology and how that really aligns with what healthcare is today. You know, on the show, we've talked a lot about innovation and telehealth and digital innovation in healthcare, and you know that just seems to line you up perfectly with this where medicine is and where it's heading.
Exactly. I think I've just become very accustomed to not following one path. And that's exactly what technology has been doing to the medical industry. We've really been disrupted with how we think our future is going to look in really great and exciting ways. But I think part of the problem we get into then is that people feel very resistant because the future ends up looking like something we never even imagined. And if you're not open to the idea of taking a pivot and a left-hand turn when you thought you were going to go right, that's a recipe for disaster in today's healthcare environment.
Yeah, it makes me think of the saying, change is the only thing that's constant. There's something like that.
It's trite, but it's absolutely true.
Yeah, it is. So you've worked across bedside care, leadership, academia, and innovation. What moments in your career helped you to see where the real cracks in healthcare exist?
I think, from the 30,000-foot view, I'll just say that having the perspective of viewing healthcare from multiple different lenses
Mm.
has really helped me see when there's a common issue that happens across all of the different roles that I've experienced, those tend to bubble to the top for me. And the technology industry that I was involved in way back in the day was facilities management. And it was about, we worked with customers, hospitals, and nonprofits, typically universities, research universities, managing their space. And in that process, one of the things that I learned, that this was back in the 90s, was that buildings would be built, units would be developed, and nobody would ever ask the end user, hey, what do you need this to look like? And so they'd end up pouring all of this money and all of these resources into building an absolutely beautiful space. But then what they realized was the space didn't work for the people who have to actually use it. So now, fast forward, my own personal experience a month ago in the healthcare world, having an appointment and seeing a specialist for a test. And she unprompted went off on a story about, we're in this new space and it's so pretty, but it's such a mess. I had to actually ask them to rip out everything they had designed and shift the design of the room because it wasn't functional for me to use. And so then all of a sudden I saw this aha moment of,
Hmm.
wow, this is the problem. And I think to me, that is the biggest crack that we tend to always see come up, is that we don't engage the frontline workers
Hmm.
in any of the processes we develop. We try, but we're not always intentional, particularly when we're working with third-party units, whether it's a software tool or a physical space design. We just don't ask the end users. So, story from my ICU days was that we were having an increased incidence of injuries on the floor. Patients tended to be more and more obese over time. They would be 100% dependent on us. So it was very heavy lifting. And the unit and the leadership saw that this was a problem. And so they swooped in saying, we've got to give you a solution, which is fabulous. But they built a solution of lifts that were stored way down at the end of the hallway where you had to plug them in with a battery that only lasted for 20 minutes. Well, in an ICU setting, in a unit that was set up in a very longitudinal way, where if you were assigned at one end, it was a pretty significant walk all the way to the other end to get the lift. Not only would we not walk to get the lift because it was in a crisis moment where we would need to use it, but we certainly weren't walking back to plug it back in. And so within the first day, they were all dead and none of the lifts were available for us to use. It's just a simple example of how a lack of engagement of those people who are actually using the solutions that we're building, if they're not intentionally brought in at the very beginning with those design discussions, we're really missing the boat.
Yeah, and I've experienced that for sure. One thing that I think about is working for a school, and somebody somewhere made the decision that we were going to roll out iPads to every student, every faculty. We got the Apple TVs. We were wired for sound with the Apple products. That did not talk with our learning management system.
Very simple.
So, yeah, and that didn't really make anybody happy. So then it was like, well, we're stuck with these. We've already signed the contract to give these to every student. Like, okay, now how do we make this work? Instead of, like you said, having that foresight to bring in a bunch of different people that see things from a bunch of different perspectives to really get the big picture of things.
Exactly. And how many resources do we waste on well-intentioned but
Mm-hmm.
poorly designed solutions?
Mm-hmm.
The retrofit and the amount of money that goes into that is just lost money. And in an environment nowadays where healthcare is really being squeezed financially, that is something we have to start paying attention to.
Absolutely. Because we have limited resources as it is. Speaking of limited resources, how did your early clinical experience shape how you think about retention and burnout and the types of support that these frontline peoples need today?
Yeah, interesting question. And I guess for me, when I think about this question and my early clinical experiences, I will share I grew up in an era where nurses eat their young. And I'm sure that is a statement everybody has heard before. It really was the culture back in the day, but I am firmly Gen X. So if I came into a situation and my preceptor or my nursing faculty was harsh and, militant with how they would treat me when I came on the unit, my response was, "Oh gosh, okay, I'll do better. I'll just take it. I'll do better. You're right. Yes, ma'am." And I think what we're seeing now is a shift, not unfortunately with the eat your young, and for very different reasons, but we still have a problem with what I would call lateral violence, where a student, for example, will walk onto a unit, very excited to be there. I'm going to be your student nurse today. And they're met with rolling eyes, a big sigh, "Oh, what am I going to do with you today? It's going to be really busy. I'll do my best, but, you're just going to have to follow along." It's not a warm and fuzzy environment. So, still very much an eat your own kind of a mentality. I think what's shifting is as we go through generations of nurses and how they are raised, quote unquote, to become a nurse and a professional, they are less willing to put up with that kind of a response from people. So now instead of a "yes, ma'am, I'll do a better job next time," it's sort of like, "Whoa, this is not okay. You do not treat me this way." And I applaud the younger generations for having a better backbone of being able to say, "This is not okay and this has to stop now." I think the problem we're running into, though, is that the solution for them, instead of being confrontational, oftentimes is to say, "This isn't working for me. This is causing too much personal stress. I'm going to have to leave the position." And I
Yeah.
do think that contributes to the burnout and the retention problems that we're seeing. I think that's one of many issues we see.
Yeah, I can think of a situation where I had a student that was at a clinical site. I was managing a surgical technology program, and on Fridays they would come to class, come to campus for a certification prep class. And so she had this big old bruise on her arm right here. And I said, "Oh my gosh, what happened to your arm?" Well, she didn't at first want to talk about it. So later after class, she approached me and she said, can I talk to you?" And I was like, "Sure." So come to find out, one of the first assists in one of the cases she was doing, she went to grab something and he literally grabbed her arm so forcefully that it left a bruise on there. Like, you could see his fingerprints on there. And she said, "I told the charge nurse," and the charge nurse said, "Well, that's just the way things are around here." And I was like, "They most definitely are not that way around here." So I'm going to take care of that. So I think putting those advocates in place too, being advocates for our fledgling nurses or, frontline workers, whoever. And then it also makes me think of the complete opposite. When I was a baby surge tech, my preceptor made all the difference in the world of whether I fled and never came back after day one or I came back. She was very supportive, and I was extremely lucky to have, been partnered with someone that was so supportive and really fantastic. Otherwise, I don't think I would have made it, honestly. If you just have that one person in your corner that you can go to, that makes a difference.
Exactly. And I think it takes a village. We all have our moments where I am absolutely in the weeds, to borrow a restaurant term. I cannot breathe air. I've got a straw, and that is my lifeline because I'm completely underwater. It's okay for somebody to tap out, but the whole unit has to participate in filling those gaps.
So if we rewind time and go back to when you were first starting and you were a new nurse, what are some things that you wish would have been different in your experience, or how you felt you could have been supported better?
Well, I think for me, honestly, that answer is more important for today because I will tell you, when I went back to nursing, again, it was a career change. I had to go through some refresher training because I had graduated, and it took me a couple years to finally make the switch from my former role to my nursing role. And so I was given a very fluid custom orientation, meaning that first of all, I was connected with a nurse who had been a nurse for 20 years. She was my preceptor. She was the only preceptor I worked with. There was one other nurse, also a nurse for 20 years, who was my backup preceptor. So if mine was sick or had to take a week of vacation, I always knew who I was going to work with that day.
Mm-hmm.
My manager checked in with me on a regular basis. Okay, you're on day 3 of X number of days of orientation. How do you feel? You have 3 days left of orientation. How do you feel? Are you ready? Do you need more time? And fast forward to today, I understand that there are some necessary reasons why orientation has become more standardized. A dear friend of mine loves the term, let's standardize and optimize things. And there's a lot of business sense in that, right? It makes sense if you can create a process that you can duplicate repeatedly over time. What's lost, though, is that personal customization. How does that particular nurse respond to the training that they're receiving? Some have a lot of confidence and they're ready early. Great. End orientation early. Some are really feeling very unsure of themselves, are taking some extra time to learn. Give them some extra time on orientation. I think that customization is critically important. I think it's especially important nowadays because, again, with my story, both of my primary preceptors had been nurses for decades. That is just not the case anymore. Our workforce is mobile. As we're talking about, we're losing a lot of experience, both through retirement, through decisions to leave the bedside, through career opportunities. And so the level of expertise that's being tapped for precepting our newest grads don't necessarily have that deep bench of experience themselves. That changes the trajectory of how long it might take somebody to get oriented in a position. So for me, I think that's the real shift where we have to ask today, how could we go back to how it used to be and maybe compensate for some of those things? We don't have that deep bench of experience the way we used to. So what else can we tweak with this standard program of orientation to make sure that everybody walks away feeling supported? That's the big question I think we have to ask ourselves.
If nurse retention is about more than individual resilience, then the real question becomes, how do we redesign the systems that shape a nurse's first year? In the next episode of this series, we'll continue our conversation with Heidi Sanborn and explore how leadership, mentorship, and innovation can create environments where nurses feel supported, not siloed. Thanks for listening to The Exam Room.